Pericarditis in CKD end-stage kidney disease patients. So uremic pericarditis usually occurs at the beginning of starting dialysis, usually less than 8 weeks of starting renal replacement therapy. However, dialysis-associated pericarditis occurs more than 8 weeks of starting renal replacement therapy, more so in an established end-stage kidney disease patient. You look for fever, patient is usually feeling unwell, he has low blood pressure, hypotension, high BUN or azotemia. Usually they're non-adherent to treatment, they skip dialysis sessions. Look at the heart, they will have sinus tachycardia, intermittent leathery cardiac rub, and the key here is intermittent. Sometimes it appears, sometimes it does not appear. The EKG shows low voltage or non-specific T-wave changes, cardiomegaly with pulmonary congestion, small bilateral effusions, and this is by echo and chest x-ray. Common cause of hypotension on hemodialysis: either acetate, dialysate with acetate instead of bicarb. Patient has a low serum sodium or calcium or magnesium, or excessive ultrafiltration. So you either have something in the dialysate, something in the serum of the patient, or you're removing extra fluid. Ways to decrease progression of cognitive impairment in end-stage kidney disease. That's somehow related to the previous question. You should decrease the ultrafiltration rate, which decreases the frequency and severity of HD-related hypotensive events. What's the performance of RO system equation or measurement? That's more of an engineering kind of question. So you measure it by something called rejection rate. What's the rejection rate? You practically do the feed water total dissolved solutes minus the permeable water total dissolved solutes divided by the feed water total dissolved solutes. The typical rejection rate is more than 75% to 100%. That means that the RO system is good. Hemolysis in patients from disparate units. The key here is disparate units, malfunctioning or faulty machinery or tubing system. End-stage kidney disease presenting with fatigue, weakness, depression, erectile dysfunction, and decreased libido. Think of testosterone deficiency. Also check thyroid function. End-stage kidney disease with fatigue, weakness, and declining serum albumin level. Do nutritional assessment. By the way, high creatinine on dialysis patient does not mean under dialysis. It means that they are good nutritional status. Carnitine deficiency in end-stage kidney disease patients leads to: number 1, relative resistance to EPO, causes a little bit of hypotension, cardiomyopathy, some muscle cramps, inflammation, and lipid abnormalities. Historically, for every CKD end-stage kidney disease patient, you used to give it orally or check for it. Thiamine B1 deficiency in end-stage kidney disease. So thiamine is the cofactor for transketolase, including erythrocyte transketolase. Features, if it's deficient: Wernicke-Korsakoff encephalopathy, heart cardiac output failure, which is the beriberi, ataxia, ophthalmoplegia, confusion. Treatment: you just give thiamine 100 milligrams QDPO. Usually thiamine decreases by 6% after each HD session. Catheter-related bacteremia, how to manage that? IV vancomycin, guide wire exchange. The inner biofilm is the major source of infection. Treatment of MSSA or methicillin-sensitive Staph aureus bacteremia. You give cefazolin IV 20 to 25 milligram per kilogram after each dialysis session. So this is a tricky question, and unfortunately you have to know the reference to answer this question. Ultrafiltration versus diuretics in terms of outcome. So usually per studies, isolated UF is more efficient at removal of excess fluids and rate reduction. There is no potential benefit on kidney functions, length of hospital stay, or mortality. Then you have this avoid heart failure study. They compared the early single session of isolated UF versus the adjustable diuretic dosing. Similar survival and kidney function. However, UF was associated with fewer heart failure and cardiovascular events, but more serious adverse events, all organs. Then the CARES heart failure in New England Journal of Medicine, they looked at stepped pharmacotherapy algorithm, which was superior to UF for preserving kidney function. at 96 hours with a similar weight loss between the two strategies. Meta-analysis of isolated UF versus diuresis. Isolated UF resulted in greater total fluid removal, greater reduced risk of worsening heart failure, however, greater rehospitalization without worsening of kidney functions. Accepted arterial and venous pressures in HD circuit. It's safe when arterial is no more than -250 and venous no more than 300. Resistance to flow through dialysis catheter with high pressure will lead to microangiopathic hemolytic anemia. What else causes microangiopathic hemolytic anemia? Artificial heart valves. It also causes TMA, thrombotic microangiopathy.